Okay, what about the anesthesia that we use? Anesthesia in general is pretty straightforward. We want you to go to sleep and not feel that somebody is, say, putting in an artificial hip joint. To me, that sounds like really painful. Like they make a big cut on your hip, and then they cut off with a saw the end of your bone, and then they hammer a big steel nail down into your bone with a ball on the end, and they pop that back into your hip socket, and then I really don't want to be awake for that. Is that clear? I mean, you don't want to be awake for that. So we want anesthesia, but we don't want any of the dangers of anesthesia. We don't want any bad side effects. So we use a variety of different medicines to manage that. For pain, pretty much the foundation of our pain relief strategy is to use narcotics. Because other mild pain relievers or non-narcotic pain relievers are pretty small potatoes. Tylenol, aspirin, stuff like that. They're for mild pain. They don't help if you have a gunshot wound or if somebody's sawing the top of your hip off. The problems with narcotics is they have their own side effects. The two big side effects they have are nausea. So if you get a big dose of narcotics fast, you throw up. Like if you ever had codeine, that's commonly, people say, oh, I'm allergic to codeine, it makes me throw up. Well, that's not an allergy, that's a side effect. Okay. The other thing is that narcotics depress your breathing. And if you're a heavy person, you're already at risk because you've got a big weight on your lungs, so further narcotic depression of breathing can be life-threatening. So we have patients who have surgery, they come out of the anesthesia and they wake up and they have pain, and we want to give them narcotics and we make them throw up and they can't breathe very well. Not a perfect situation. So a whole area of research has looked at something that's now called opioid-sparing pain relief and opioid-sparing anesthesia. The idea being, I want pain relief, can I spare, can I use fewer narcotic pain medicine dosages? And this area of research has exploded. They found two receptors in the brain that when they're stimulated by drugs take away pain. One is the alpha-2 receptor in the brain, and we use two drugs, clonidine and dexmedetomidine, to attack and work on those receptors, which decreases your feeling of pain without nausea and without respiratory depression. The other receptor in the brain is called the N-methyl D-aspartate, or for our purposes, the NMDA receptor. And the drug ketamine and Neurontin, the gabapentin, you guys know that one, right?
Yes.
Yeah. Those both work on the NMDA, the N-methyl D-aspartate receptor. And when we use those in combination, the alpha-2 and the NMDA receptor blocker, ketamine and Neurontin, we've had a tremendous decrease in the amount of narcotics used. Here's the numbers. When we use the old technique that just used the short-term narcotics, patients would require, on average, 10 to 20 doses of pain medicine per week for my 5 to 10 patients. Since we've started the opioid-sparing techniques, that dosage has been decreased to 1 to 2. So we've had a 90% decrease in the need for narcotics. We have 90% opioid sparing, and we protect your breathing because the ketamine and dexmedetomidine stimulates breathing and don't cause nausea. So that's what those patches are in your back there.
I have them.
So we're very excited, and I think you'll be really pleased. One other little thing is the ketamine that we use is an old-timey drug. And one of the problems that we face in the ER is people come in depressed. Like they say they've tried to kill themselves, right? And you'd like them to be undepressed. You want to make them happy. But if you gave them Prozac, you may know that you got to wait 2 weeks for that to take effect. So a real desire of medicine would be a quick onset of an antidepressant. Well, they took people who were depressed and they asked them depression questions. Are you sad and helpless and hopeless and stuff like that? And then they started a drip of IV ketamine. Within 20 minutes, their depression had started to lift, and within an hour their depression had lifted and it lasted for a week. So we use ketamine not for this purpose, but one of the side effects is we expect you to be happier.